am going to turn it over to Chris White, who is my colleague here and one of our social workers, and he is going to moderate this evening. Chris, all yours.
All right, thank you so much, Nori. As may have been mentioned, my name is Christopher White. I'm one of the clinical social workers here as part of the Dementia Care Collaborative and Dementia Caregiver Support Program. Just a brief overview of our program. We launched in late 2017 as part of the Massachusetts General Hospital Division of Palliative Care and Geriatric Medicine. Our mission is nothing less than the transformation of memory care as we know it. In addition to the research conducted in the division to improve dementia care and memory care, the Caregiver Support Program exists specifically to educate and support patients, caregivers, clinicians, and the community at large. We have a variety of programs that we offer from including, but not limited to, individual and family meetings for patients and families who receive their care in one of our specific MGH clinics. This program, Conversation with Caregivers, is offered once a month. And there are also ongoing programs that focus on health and resiliency, practical skills for dementia caregivers, and 3 support groups that we currently have that are ongoing. Our program, just so everyone knows, is entirely funded through philanthropic support. So if you're interested in learning how to support us in the work that we do with our program, please feel free to visit our website at www.dementiacarecollaborative.org, or you can email or speak to any one of our fine team members, who I will introduce right now. So when I call, name this one of my colleagues and one of our team members, just feel free to give a little wave. So we have Susan Rowlett, who is the director of the Caregiver Support Program. We have Barbara Moskowitz, who is the associate director for the Caregiver Support Program. Judy Willett, who is our senior project manager. Nori Mazzone, who's the wonderful program coordinator. And we also have Kelsey Anderson and Gabrielle Rex. They are the social worker and nurse practitioner, respectively, for our memory care initiative team. And then finally, our special guest tonight is Dr. Stephen Arnold. Dr. Arnold is a professor of neurology at Harvard Medical School and the translational neurology head and managing director of the Interdisciplinary Brain Center at Massachusetts General Hospital. Dr. Arnold has conducted longstanding research on neurodegenerative disease pathology, molecular biomarkers and therapeutics for cognitive decline, and psychiatric syndromes in late life. He's led broad clinical translational research program and has authored over 250 scientific articles, reviews, and chapters relating to the topic. His current scientific interests include biomarkers in brain aging and dementias, metabolic factors driving dementia, and protective factors that account for cognitive resilience, all with the goal of accelerating therapeutics discovery and development. And so with that, I would like to turn it over to Stephen Arnold and take it away.
Okay. Thanks very much, Chris, and welcome everybody. I'm really happy to be able to talk with you and kind of share some of our thinking here. What I'm going to talk about is kind of a mix of clinical as well as clinical research interests that I have. And I'm going to, so it's going to be pretty broad, but I'm going to take you through sort of the process that I go through with a patient who comes with a complaint of memory problems, and how we actually think about that person from a diagnostic standpoint, figuring out what's causing the problem, and then trying to design a treatment program that is very much oriented towards the individual themselves. And so I'm going to talk about a broad range of things, a little bit of clinical history for patients, a little bit of epidemiology, a little bit of biology, some aspects of treatment, and then I'll also express some of the frustrations that I've had in terms of the way clinical trials and the whole discovering new medicines for Alzheimer's disease has evolved, and how we're trying to rethink that process for research in order to how to test new things to see whether it can change the course, improve symptoms for people with Alzheimer's disease, or even prevent the disease altogether. So one of the things that, and let me just share my screen at this point. I wish we could all be together in person so that it could be more of a interactive thing. But so I'm gonna go back and forth. So, one of the things that I often, when I talk with groups, I kind of ask people, when do you, we all have changes as we get older in terms of our memory and thinking. We, walk into a room, we can't remember why we walked into the room. We see someone on the street and you just, you can't think of the person. So you know everything about the person, you know who the person is, but you just can't come up with their name. And you go through the alphabet and maybe that'll prompt the name. And, all of these things do become more common as we get older. And I sometimes start off some of my talks asking the audience when they think these changes with cognitive abilities really start. And sometimes, people will put their hand up and they say, oh, it was around menopause that it started for me. Or other people will say in their 60s. And then, I actually show them some of the data from a few large studies of aging across the lifespan. And, if you look at the way cognition, whether we're talking about memory or spatial abilities or information processing, it looks for almost all aspects of cognition, we kind of peak at around age 20, and it's downhill from there. So all of these things are changing as we got back. I actually went online and did one of these sort of games online to test your memory and see where and it was also a kind of like a visual processing speed thing. And I took it and I kind of came out in the 15th percent. I'm in my 60s now, came out in the 15th percentile. And I said, oh my God, I'm so bad. And then I looked at it in relationship to age, and I was squarely about 50th percentile or 60th percentile. So, all of us are slowing down a little bit as we get older, but it's really happening within a relatively narrow range. Actually. And when we get concerned is when people fall off this normal trajectory. And I'm sure most of you are very familiar with the terms mild cognitive impairment and dementia, but just so that we're all on the same page, I'd like to kind of describe this a little bit. So while we all slow down as we get older, it takes us a little longer to do things, come up with words, we're pretty much functioning pretty well. When people start to develop more significant memory and thinking, so that it's really, and there's a clinical judgment here, but when it's really significantly different from how they were before, and the forgetfulness is just really it strikes you as different from how someone was before. But they're still able to go about their business, and maybe it takes them longer to do things, to work the checkbook and all. But if there's a noteworthy decline, but you're still able to manage your day-to-day affairs, we call that mild cognitive impairment. And for some people, mild cognitive impairment is just the way their brain ages, and they tend to stay with mild cognitive impairment. But for other people, it can be the first sign or the first stage of something that's getting worse. And if the memory and thinking difficulties progress to a point that it does cut into a person's ability to function day to day, to manage the checkbook, to go shopping, to drive, to handle their daily independent affairs, that's when we use the term dementia. Now, there are many, many different causes of dementia. Alzheimer's disease, of course, is probably the most common in late life, but there are others, things related to Parkinson's disease, Lewy body dementia, frontotemporal dementias, vascular dementias, and a whole lot list of other things. And we'll touch on these as I go on. But I'd like to kind of talk about sort of 4 key questions that come up when someone first comes. So this is actually a patient that I saw a few years ago in the memory disorders unit. He was 75, and the details are altered a little bit, but here. But this was a 75-year-old man, married, retired executive, and his wife. He came in because he was having a couple years. His wife had been noticing more forgetfulness. He was kind of looking around in his office for important documents. It took him a longer time to do so. Had some trouble recounting conversations. He had always been really good with technology, and he was having some trouble figuring out new apps on his iPhone. But he was still very active. He was, driving, cooking, taking care of chores at home, attending class, a little bit more withdrawn and quiet. And the questions that they come to me, or any of us in the memory disorders unit with, are, one, is there something wrong with me? Two, if there is something wrong, what is wrong? And then 3 is, okay, something's wrong. We know what it is. What's going to happen to me? And then 4th is, is there anything that I can do about it? What can I do about it? So those are kind of like the questions that I try to deal with as I take on a new patient. And actually the questions that I'm taking on into our research in order to do better at answering all of these questions. So, when we see someone such as this man, we may give him, some of you will recognize this is a very common screening test that we do called the MoCA, or the Montreal Cognitive Assessment. And we have people follow a little maze and draw a cube, name some animals, remember 5 words. And this man, did actually pretty well, but he had a lot of trouble in remembering 5 words after a few minutes of delay, and just a few other things that weren't quite right. And he fell just below the cutoffs that we use that for what we would consider to be normal or abnormal. So here, based on the history that his wife gave and her observations, based on the way he performed on this test, we made a diagnosis of mild cognitive impairment. And as I said before, both mild cognitive impairment and dementia, there's a lot of things that can cause it. And so it is very important for people to get checked out by their physicians. They're either their primary care docs or a specialist, because there could be some things like if the thyroid gland is underactive, or if someone's, has a vitamin B12 deficiency. Those are things that can contribute to memory dysfunction. And those are things that you can easily identify and usually easily fix. And all of those different causes, are kind of grayed out in the background, because if you've looked at all those common things by doing some blood tests and making sure that there's no tumor or stroke, what we're left with in thinking about the causes of cognitive impairment in older adults is a pie that looks like this, where maybe 50 to 75 or 80% of the causes of cognitive decline may be due to Alzheimer's disease, or more commonly a mix of vascular disease, small vessel disease in the brain, and Alzheimer's disease, and then things related to Parkinson's disease, or the Lewy body diseases, and the frontotemporal dementias. And they used to say that, while this seems to be the pie chart for what's causing dementia, They used to say that you could only be sure what's happening if you were able to look at someone's brain under a microscope after they die with a brain autopsy, and you'd look at the under the microscope, and you'd see things that we call plaques, amyloid plaques, and tau tangles. We'd see the Lewy bodies of Parkinson's disease. We'd see mini strokes or vascular problems in people with vascular dementia, or we would see other kinds of cellular abnormalities in frontotemporal dementias. And this was all discovered 100 years ago, 110, 20 years ago, many of these things. And over the past century, and especially in the last 30 years or so, we understand an awful lot about some of these lesions that cause Alzheimer's disease. So we understand now that those plaques that Alois Alzheimer described back in 1900, we know that they're made of an abnormal protein molecule that we all have in our brain, something called amyloid, that for reasons that are still unclear in people who are developing Alzheimer's disease, this amyloid protein kind of misfolds and crumples up. And when it crumples up, it kind of causes an inflammatory response, and it can cause brain connections to die. And then similarly, there's the other major cause or thing that you see under the microscope in the brains of people with Alzheimer's disease are these neurofibrillary tangles, which are made of another protein molecule called tau, and that also can crumple up and disrupt and actually cause the death of brain cells. And when these things accumulate over time, it actually can cause the whole brain to shrink and degenerate. And as the brain shrinks and degenerate, that's what causes the dementia. So that's probably the main way in which most of us think about the understanding the biology or the pathology of Alzheimer's disease. And I could say a similar story for some of the other types of dementia, analogous stories. But I said we used to say we could only be sure about the diagnosis of what's causing someone's cognitive decline and dementia by autopsy. But now, especially in the last 10 years, 10 to 15 years, we have a host of what are called biomarkers. And so these are things that we can measure either using MRI scans or PET scans or blood tests or spinal fluid tests, things that we can measure during life that can tell us with a very high degree of certainty, maybe 98, 99% certainty, what would be under the microscope if we could see it at that point. And so, for that man that I told you about who was developing mild cognitive impairment and he wanted to know what was going on with him, we did an MRI scan and we saw a little bit of, on the MRI scan, this is, I'm focusing in here, circling an area of the brain that's especially important in memory, an area called the hippocampus. And in Alzheimer's disease, we do see shrinkage of the hippocampus, even at early stages. So this was a tip-off that that maybe there was some Alzheimer's disease that's developing in this person's brain that's causing his cognitive decline. But more definitively, we did a spinal fluid test, which is a fairly simple office procedure, where we measured the levels of the tau proteins and the amyloid proteins, and found that he had the levels of these proteins were abnormal for all three of them, basically confirming at this early stage that he did have Alzheimer's disease that was forming up in his brain that was likely, very likely, to be causing the cognitive decline that he was experiencing. And what we now know from all of these different biomarkers that are measured in research group, in people that are participating in research across the lifespan, is that we can see some abnormalities in these biomarkers for amyloid, for tau, for brain metabolism, for brain shrinkage. We can see them years to perhaps even decades before someone really develops significant symptoms of the disease. So on the one hand, this is kind of depressing. Oh my God, I may have Alzheimer's disease in my brain now. But on the other hand, if we can recognize these things early, and if we had some medicine or some intervention that could stem the tide, perhaps we could actually prevent the disease from taking hold or causing problems to begin with. And so that's really the opportunity that these biomarkers have presented to us now. And as you know, there's just furious work to try to develop drugs that can actually stem the tide of this disease. Now, one of the issues, and the next question that this man would have had for me is, well, what is going to happen to me? So I have Alzheimer's in my brain. I've got mild cognitive impairment. How long do I have, doc? And that's where our knowledge base starts to fall apart to a long degree. So if you take 1,000 people or so, and this is work in a very large group. I worked with this group for a number of years, the Religious Orders Study and the Memory and Aging Project. These were older adults who were coming in once a year for memory tests, and they all agreed to brain donation after they died, and about 1,200 of them had died at this point. And if you look at the amount of Alzheimer's disease in the brain, the amount of plaques and tangles in relationship to how much cognitive impairment, how impaired their memory was, you can definitely see that the more plaques and tangles that you have, the lower your cognitive abilities. And that's when you average everyone together. So clearly, the more Alzheimer's disease you have in the brain, the more impaired you are. But if you really want to look at what the data looks like at an individual level, it's more like this. And I can't tell you how many hours I've stared at this graph, thinking about all these different dots and what they mean. And so you have people who have high levels of Alzheimer's disease in their brain, and yet their thinking and memory was perfectly normal. And this is at the time that they died. And so while the average shows a strong relationship, why is it that some people can have these plaques and tangles in their brain and not get demented? And similarly, what is the course of people who do have Alzheimer's disease? Some people have a relatively rapid decline over a number of years. Some people have a slow decline in this green line. Some people don't seem to change much at all. Some people may have some change and then a precipitous decline. I don't know about this particular person. Maybe he or she had a stroke or something that caused them to really decline. But I think, again, looking at this in people with Alzheimer's disease pathology and in their brain, and seeing how heterogeneous the course is, you scratch your head and you wonder, why is that? How is it that my Alzheimer's disease could be so different from your Alzheimer's disease? And so one of the things that we recognize now is that there are many drivers for Alzheimer's disease. And it would be nice to say that if there's amyloid then that's what's causing the problem. And if only we could clear the amyloid out of our brain, we could stop this terrible disease. But the way many of us think about this now is that there are these amyloid plaques and tau tangles and misfolded proteins, but whether it's a cause or a consequence of these other more fundamental biological factors going on in our bodies, inflammation, oxidative stress, vascular disease, different effects of genetics or epigenetics, metabolism, how metabolically active or abnormal, or what kind of metabolic abnormalities we have with aging. All of these things kind of work as in vicious cycles to, I think, drive the degeneration that we see in Alzheimer's disease and other dementias, because these factors are important for the other types of dementias as well. So one of the things that we've been doing in our research, our biomarker research in the lab, is seeing how we can better understand the heterogeneity of people. How is it that your Alzheimer's may be different from my Alzheimer's disease? And can we use that to design a treatment or select a treatment that may be especially helpful for you, which may not be as helpful for someone else? And so in the lab, this is Chris Ramirez, who's one of our technologists running some of the fancy machines that we have in the lab, where we look at spinal fluid or blood plasma, and we look at a large number of molecules. We look at amyloid and tau levels. We look at different kinds of markers of inflammation. We look at markers that might indicate that the blood vessels are leaky or that they're degenerating. We look at different metabolic factors related to diabetes or cholesterol metabolism. So we basically try to profile what's happening. And if we take, and this is a graph showing the different levels in an average of about 50 people with Alzheimer's disease, we can see that, there's a little bumps here and there in this. But, what we're really doing is taking 50 people or 1,000 people and averaging them all together. And this is one of my pet peeves about Alzheimer's research now, is that we just take everyone and we bunch them all together, and then we average them, and we get a person that looks like this, this Joe, 799K. And I don't know about you, but I've never seen a person walk into my office who looks like this. I've seen other people that, I've seen Joe Stone, I've seen Joe Parker. I've never seen an average. But when we break this down and look at the individual levels, we see, here. So this is one person within that group. And, we do see that this person's amyloid and tau levels are high, but this person had enormously high inflammation markers. And that's distinctive. That doesn't look like the rest of the group. And then I look at Joe Parker, and I see that his inflammation markers are, a little bit elevated, but not much. But he shows a lot of different markers showing that his blood vessels are inflamed and that the blood vessels are leaky, going to the brain and probably other places in the body. So what we start to see is that people, not only are they different in the way that they show their cognitive impairment or progress along the course of Alzheimer's disease, but they're different in these biological factors that may be driving it. And so I'd like to now move into, in the next 10 minutes or so, talk about treatment and how we currently treat Alzheimer's disease, why there's a problem, and how we can use maybe the strategy of personalizing treatment to do a better job, which is a big aspect of the research that we're doing here. So as most of us know, we don't have a whole lot that is very helpful for Alzheimer's disease. This is everything that is currently approved by the FDA. 3 of these medicines, Aricept, Exelon, and Remenil, all work with the same mechanism. They try to boost acetylcholine, which is one of the brain chemicals that's deficient in Alzheimer's disease. And as I typically tell my patients, it's worth trying. It may provide some modest benefit for some people. And that's about as enthusiastic as I can be about these medicines. They can be modestly helpful. Same thing with Namenda. And all of these were, these 4, Aricept, Exelon, Remenil, and Namenda, were all approved several decades ago. The new and controversial medicine that is now approved by the FDA is this aducanumab that I'm sure many of you have heard about. And this is a big, busy graph, but this was a very exciting medicine, because rather than just providing some symptomatic benefit for people by boosting acetylcholine levels or NMDA levels in the brain to compensate for what was lost in Alzheimer's disease, this medicine was designed to actually attack the amyloid plaques. And in that regard, it was and is a very effective medicine. This was one of the earlier studies a few years ago. It shows a PET scan, an amyloid PET scan, and it shows people when they first came into the study, and then after 1 year on this medicine, that it got better and better the higher the dose, but basically it really did lower the amount of amyloid in people's brains. It was very effective in that. It also seemed to help with the tau pathology in the brain and reducing the tau pathology. And yet, and this is part of the reason why it's so controversial, is that when you looked at people and who were treated with this medicine for 1.5 years, 2 years, there was no difference. Everyone in the study, whether they were on the active medicine or the placebo medicine, everyone continued to get worse. And so even though the medicine was attacking the amyloid and the tau and lowering its amount in the brain, still the dementia progressed. And this is, this is why it's so mind-boggling, and what impresses me so much about how complicated this disease that we call Alzheimer's is, that while it would be nice if it were all due to amyloid or tau, it is more than that. And that's what I think we've seen with some of those graphs that I showed you earlier from the religious orders study, and what we're seeing in the biomarkers. So based on the fact that aducanumab does not really, it hasn't been shown to provide benefit as yet, clinical benefit, meaningful benefit in people's lives. Many of us are not enthusiastic about recommending it to our patients. We want to see that it actually not only changes a protein level, but it actually changes a person's life or course. Now, this is one of my slides that I put up for just visual effect, because we may already have the successful treatment for Alzheimer's disease. All of these treatments have been shown to be effective in either lowering amyloid, decreasing tau pathology, improving memory, but so far they've only shown these effects in mice. So some of us say nowadays that it's a great time to have Alzheimer's disease if you're a mouse, because we have lots of effective treatments for you. But the real challenge has been, again, moving this into people and testing it. And from my perspective as a clinical researcher, how do we choose among these 300 people, 300 different drugs and herbal remedies and other things that have all shown benefit? How do we move this into people? Now, you have to think, the mice that they use in these experiments, they're genetically identical. They're all treated and raised in the same cages with the same diet. These are totally uniform mice. Well, I'm sorry, this is not people. People are heterogeneous. They have all sorts of genetics. They have all sorts of environments. They have all sorts of experiences. They have all sorts of diets. And so it's really hard to say this works in a mouse, it's going to work in a human, because you have to really try it. So one of the things that we're thinking of, and this is here Joe Stone again, is that Joe Stone, with his spinal fluid studies or his blood biomarkers, has a lot of inflammation in his blood. Maybe that's telling us something. And maybe in addition to an anti-amyloid medicine, we should use one of those medicines that was on the list that I just showed you that have been in animals, that we know may work in animals, but maybe Joe, who has a very high interleukin-6 level, meaning that he's got a lot of inflammation, maybe he should also be treated with an IL-6 medicine, teclistamab. I don't know. We haven't run this study, but this is what we're trying to move. We're trying to use what we can learn about an individual and their biology and try to match the right person with the right medicine. And as I'll go on, design a trial that actually can measure a meaningful change for that individual. So, here's Joe Parker with the vascular markers that were abnormal. Maybe we should look at some of these other things that have been shown on that list of mice that have worked that affect the vascular system. So my next pet peeve, aside from the choice of medicines, but my next pet peeve about clinical research is that, when we want to measure whether someone's doing better or not, we do the same, we have these tests, one size fits all tests. So, we're going to give you 10 words and we're going to give you 3 tries to learn those 10 words. And we're going to ask you them back in 5 minutes or 10 minutes. And based on that, we're going to tell you whether your Alzheimer's is getting worse or better. And we're similarly, going to give you some symbols to draw, and we'll see how you do with those and see how you remember them. But again, we make these big clinical trials. We give everyone the same test. You sleep well on the first day of the trial, and you do really, you do okay on the test. You sleep poorly on the last day of the trial, and you do poorly on the test. And even if the medicine was working for you, you're going to say that it didn't work because you didn't do well. And so I think what we're trying to think about is when we design our research and how we measure whether someone is benefiting or not, can we make more personalized, smarter outcomes? Because what's important to you could be learning a list of words. I don't know. It could be learning being able to remember your golf score with your friends. And for another person, it may be, remembering how their way around the kitchen and how to make a cup of tea. And for someone who's more severely impaired, they'd like to be able to remember how to put their jacket on. And another person may want to be able to continue to email with their grandchildren. And so can we actually identify meaningful functional measures to help us understand whether someone is getting worse, getting better, or staying the same as they go on to a particular treatment? And we've got lots of these different kinds of games that we can do at home, and we can have people wear Fitbits, and we can, do EEGs in the office. So these are things that are easy and less expensive and can really start to personalize clinical trials. So I think I'm going to stop at this point and share. This is from pre-COVID times. Some of the people in our group, who are doing all this work with us. But what I wanted to do is kind of share with you sort of my thought process about evaluating patients, from a clinical perspective, and really thinking deeply about how to understand them using biomarkers, and how we can do a better job in terms of designing clinical trials so that we can perhaps choose and use one medicine or natural product or dietary supplement or exercise initiative and bring in meaningful, personalized treatments and outcome measures to better prevent and treat Alzheimer's disease. So I think that's kind of what I wanted to present, and I hope I've left plenty of time for us to have some conversation.
Absolutely. Thank you so much, Dr. Arnold. That was great. I think that was very informative in terms of where we stand when it comes to memory care evaluation and treatment, which I think a lot of people definitely have questions on. So as we go along, please feel free to type your questions into the chat, and I can go through them. And I'll start with a question. Is there any general average time that it takes for plaques to develop if I or a patient has a clear MRI or PET scan, presuming that they can still develop? So is there any average time that it takes for a person to develop, plaques or tangles?
Okay, so the biomarker studies, have many of the biomarker studies that have looked at people before the disease occurs, have been in the rare genetic forms of the Alzheimer's disease, and in people that carry these mutations, who are very rare, where they're developing Alzheimer's disease in their 50s. From those people, we do know that those amyloid plaques and tangles can start maybe when they're 30, perhaps 20 years ahead of time. We think it's a similar trajectory in the non-genetic forms of Alzheimer's disease, which is by far the most common cause of Alzheimer's, that may, start to show itself in people's 70s or 80s. That it may be a window of 10 to 20 years before someone gets symptoms. But as I said, there is so much heterogeneity. There's so many differences among people. And you may have no detectable amyloid plaques in your brain now when you're 62, but it's possible that when you're 64 or 65 that you would be able to detect some. And then for you, what would that mean? That, well, maybe the average would be that you wouldn't get any memory problems until you're 78 or 80 or your mid 80s. But it could be that you could live to 98. And even though you have, as I said, plaques and tangles in your brain and high amounts of them, there's about 5 to 10% of people who die in late life in their 90s with very high levels of amyloid plaques and tangles, and they never had dementia. So this is still part of the mystery that we're trying to unsolve. So while I can give you numbers, I can give you averages of the prognosis. As I tried to impress upon you, people are different, and I try to, when people ask me these questions, that in my clinical practice with them, I say I've given up trying to predict whether it's going to be 3 years, 8 years, or 20 years before this really catches up with you.
Great.
I wish I could give a more satisfying answer, but I just can't.
Great. The next question is, what is the latest with aducanumab? Is it going back to research?
Well, so aducanumab, so I think the main controversy for me with aducanumab is that the FDA approved it, and most of us don't think they should have approved a medicine that has some very significant potential side effects and dangers to it. That there should not have approved a medicine based on a biomarker alone without convincingly demonstrating that it has clinical benefit. So that to me is the very disconcerting thing. I still think, and some of us think that aducanumab may be helpful. Maybe if you can eliminate the amyloid plaques and the tau tangles 10 years in advance, when you first see them and someone is still normal in all their memory and thinking, maybe that will prevent Alzheimer's disease, but that study has never been done yet. It does appear that by the time someone has symptoms, either mild cognitive impairment or early dementia, that it doesn't seem, at least the data right now, don't show that it slows it down in a meaningful way. I think it was premature to approve the medicine for general use. I think that I would like to see more data before it's really ready. And so the other two things that are controversial about it are, one, its price. It's going to be between $50,000 and $100,000 a year between the MRI scans that you have to get 4 times a year with it, and things like that. And insurances aren't going to cover it unless unless it has demonstrated clinical benefit. But then the other thing about aducanumab is that 25 to 35% of people develop a side effect called ARIA, amyloid-related imaging abnormality, where they can actually develop brain swelling and hemorrhages in the brain, some of which can land people in the hospital, or even cause things like seizures and coma or stroke. So most of those, that 25 to 35%, is asymptomatic. People don't have symptoms, or maybe they have a very mild headache, but you don't know. So that's why there is danger associated with treatment. There is risk, and does the risk outweigh the benefit when the benefit hasn't been convincingly demonstrated? That's my issue with this as well.
Great. Thank you so much. The next question is in regards to the SMART and testo biomarkers. This individual said that it's terribly exciting, but they're wondering when this, individual testing and biomarkers will be available for the general, sort of public. This individualized testing and treatment.
Yeah. So what we're trying to this is something that we've been working on and developing the methods and the design in our research, excuse me, for about 2 or 3 years now. And we're at a stage now where the protocol is being developed so that we can operationalize this and implement it. It is a novel, non-traditional approach. We are, working on kind of adequately funding it through philanthropy and through, grants and from foundations and National Institute of Health. But we're ready to operationalize it on small scale at Mass General. And I think with some successes, it is, it'll, when we demonstrate some further success, hopefully within a year or so, it'll be more widely adopted. In the meanwhile, it's something to kind of, we're trying to spread the word.
Great. All right. The next question I have here is, how likely is it for someone with dementia to have a change in personality? And they give an example of someone who is happy and content in spite of a marked memory loss. How likely is it that they will become withdrawn and or negative?
Okay, so there's a lot to unpack with that question. And so, personality changes are common. They're not necessarily the rule in Alzheimer's disease, but they are common. And they can go in several different directions. Something we call apathy, or that withdrawal or the lack of initiative, is a common change in personality that you may see at different stages of the disease. And, that could be a person is becoming apathetic, or they're not planning what their day is or showing initiative because they just can't kind of think and stay organized or remember enough in order to execute a plan. And I guess you could call that an aspect of personality. More disconcerting, though, are some of the negative things that maybe you were alluding to, the irritability, the depression, the agitation. And again, those things are not uncommon. They're by no means the rule, but they're not uncommon. And they happen, and there are a number of different strategies for helping. Some are just tips for how to better help someone in their day-to-day life, through counseling, through new strategies of communication. Sometimes medicines are necessary, and medicines can be enormously helpful. A little bit rarer, there are some personality changes that you see that can be positive. And I've actually seen, wives describe their husbands who are always kind of cranky and irritable, and they've just become so pleasant and so easy to interact with now, and so appreciative of everything that they do. So, that's another personality change that can happen.
If only we were all so lucky. All right, so the next question, how do you take into account a patient's report of having a gene detected on 23andMe testing? I guess, what is, a better maybe sort of way to answer or ask that is, what role do genetics play in evaluating for any possible dementia spectrum disease?
Yeah. So, there are certain genes. So I mentioned those very rare forms of Alzheimer's disease that are caused by, these mutations in a particular gene. And that's not what we're talking about here when we're talking about 23andMe. So 23andMe is you can spit in a bottle or send them a blood or something. And, they'll screen a lot of different genes, and they'll tell you that your risk is higher or lower for Alzheimer's, for atrial fibrillation, for diabetes, for obesity. And, a couple things, one, just from a technical standpoint, sometimes they're wrong when they give you a certain genotype. So that's something to think about. But let's just presume that they're right. The main gene that people come and they ask about is a gene called ApoE, or apolipoprotein E. And, if you are, and this is a gene, a type of a gene that if you carry one, because we all carry two copies of genes in our throughout every cell in our body. One gene comes from our mother, one gene comes from our father. And if you have this type 4 gene, if you have one copy of it, then your risk is a little bit higher than the general population for developing Alzheimer's disease, but not that much higher. So if the lifetime risk of developing Alzheimer's disease is 30% or 35%, then your risk might be 40%. It's really not that much. And because of that, we don't routinely in clinical practice test for these genes because they're just not that helpful in terms of predicting whether someone's going to get Alzheimer's disease or not. They're they're a modest risk factor. And so, they're just not all that helpful. I think that, like anything, I actually did 23andMe, and I found that I have a higher than normal risk for developing atrial fibrillation. So, it doesn't mean I'm going to get atrial fibrillation, this heart disorder, but it says, maybe I'm at slightly higher risk. Maybe I should take better care of my cardiovascular. So I think, for me, that 23andMe is sort of like a little nudge that we should all do better in terms of the things that we can do in order to prevent a disease from happening. But it by no means is a guarantee, and it actually causes a lot of worry. One time I saw this, brilliant kind of MIT graduate. He was 35 years old, and he had done 23andMe, and he came up with a ApoE 3, 4, and he comes to me, as a memory, a later life memory specialist, and he wants to know what he can do now to prevent, because he's going to get Alzheimer's disease when he's 80. And I'm saying, just, go home, get some exercise, work hard, take care of your stress, eat well, and don't worry about it.
Great. All right. The next question, are you working jointly with the Brigham and Women team on their clinical trial of a new nasal vaccine to assist in slowing the progression of dementia? This person said they saw it on the news recently, really early stages with only 16 participants.
Yeah, so that is early. We work kind of hand in hand with the group at the Brigham. And we typically run some clinical trials on our side. They run clinical trials on their side. We actually share, if in people that come to participate in clinical trials at either site, we say if you're not eligible because you don't meet, the criteria, or this isn't the right trial for you, here at the Brigham, we'll send you over to Mass General and you may qualify. So we work closely with them. That the nasal delivery is just a different, it's like it could be a pill, it could be an infusion, it could be something you spray up in your nose. So we're all very, very active, and as I used the term earlier, furiously trying to find a medicine that works.
Right. The other question I have here, is it suggested to keep your inflammation to a minimum in your body, and how would you test inflammation? I'm assuming this is relating in terms of risk of developing memory loss or some form of dementia. And as a follow-up to that, does that mean eating sugar is out?
Okay. All right. So those are, we're talking two things here, two of my favorite topics right now. So inflammation, I kind of showed you those biomarkers. Those are the things that have emerged in our research over the last few years. I would caution you that it's not ready for prime time. And so I would not go out and get an interleukin-6 test or a TNF alpha test now. Those biomarkers for inflammation are guiding our research and our clinical trials that we're testing now. So that's just the caution. That said, inflammation is more broadly speaking, is a good and bad thing, right? We need inflammation. If we get an infection, you need the immune system to respond, create inflammatory markers that will attack the bacteria or the virus that you caught. So if you injure yourself, you twist your knee or cut yourself, you need inflammation to kind of help the healing process. So, but what you want to do is you need enough immune response, enough inflammation, but you don't want too much. And what we think happens in Alzheimer's disease is that there's too much inflammatory activity in the brain. So how can we determine how much of that? Can we do it from a blood test? Right now, not quite. Can we do it if we measure spinal fluid proteins in biomarkers? Better. Is it for certain? No. So what I would say is that we want to control inflammation. We want inflammation to exist within a not kind of like a Goldilocks thing, not too much, not too little. So you don't want to be taking powerful anti-inflammatories like prednisone or some other powerful anti-inflammatories, because maybe it'll help a little bit with one thing, but it may harm your ability to respond to another thing. Okay, so let's move on to sugar. So, sugar, diabetes, these are things that, again, we recognize are risk factors for developing not just Alzheimer's disease, but also vascular disease and heart disease and other things. And pre-diabetes, or even low forms of diabetes or diabetes itself, can cause a hyperinflammatory state as well. So, I think that my general tendency is that we do check for diabetes. We do check to see whether someone has any metabolic problems that cause insulin resistance. And I've got a whole other lecture on that that I could give another time. But, again, thinking about the things that we can do to prevent brain failure or dementia, kind of like heart failure, physical activity, sensible diet, preventing diabetes, kind of decreasing, managing, things that can cause inflammation in the brain, leading as healthy a lifestyle as we can is what we think will be most effective at at prevention at right now, at least until we find the magic pill, if we ever find the magic pill.
Great. All right, the next question's a bit of a long one, so I'm just going to read it verbatim. So we've seen amazing developments in the treatment of cancer in the last 15 to 20 years, in large part by no longer viewing given cancers as being monolithic, but rather being a constellation of different disease subtypes. Given heterogeneity in the profiles of Alzheimer's patients, how is research evolving to perhaps view the disease in a similar way to how we now view cancer and have been able to develop more effective targeted treatments? Are there promising studies underway along those lines?
Yeah, so that's a great question. And, you know, I think I certainly, and I think a number of us take a lot of inspiration from the huge successes in cancer. You know, and a lot of those successes are based on understanding the complex biology of cancer and the personalized aspects of cancer. So, you know, if you have a certain subtype of breast cancer or some other kind of cancer based on some molecules or genetics, you know, you can tailor the right treatment to the right person. And I think that, you know, that is really serves as some of our inspiration for where we're moving. I think, you know, thinking of it in, and you know, all I can say to that question is yes. You know, that is the right question, and that is where, you know, I feel like we have to go, and it's just going to take time. You know, one of there are some unique challenges about Alzheimer's disease, and I'll say not just Alzheimer's disease, but brain diseases in general. You know, you can't cut a piece of cancer out and study it in a dish like you can you can't take a piece of brain out and study it in a dish like you could with cancer. You know, even something like heart failure, heart disease, you know, we don't have the tools. The brain is just a harder, more complex organ than any of these other things. But, you know, it is the way we have to go because of the degree of heterogeneity, because of the degree of complexity, and because I think we've seen the way forward from some of the work in cancer.
Right. The next question, I believe we have time for maybe a few more. The next question is, can you discuss gender differences in dementia types and its prevalence?
Okay, so yeah, that's a complicated question. As all of these, I'm sorry, I keep saying that because they are complicated questions. So there are some, you know, for reasons that are still I don't understand, there are some differences among the diseases. So Alzheimer's disease is a bit more common in women than in men. You know, it may a lot of the difference may just because women live longer than men. And so age being the biggest risk factor for Alzheimer's disease is, you know, would be more common in women who live longer. But even when you account for that, there are some differences. And people have looked a lot at what those differences might be and what the effects of estrogens are and what the effects of losing estrogens in menopause and what, you know, the advantages of estrogen supplements, and is that going to prevent it to happen? And I'm no expert in that area, but I've not been struck by any major kind of effects. I tend to think that with Alzheimer's disease, women and men have much more in common than differences. And 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 then you look at Parkinson's disease, and in Parkinson's and Lewy body diseases, there's a clear preference. Men much more commonly get it than women. Again, I don't know, is that a testosterone effect? If we're thinking about hormones, is it some other kind of, Y chromosome linked effect? Is it that men are exposed to more toxic chemicals and fumes traditionally than women? And what are the effects of pollutants and environmental toxins in driving these things? We just don't know. So it's a good observation. It's an important observation. And there are these differences, but the research goes on to try to understand them.
Gotcha. Next question is there any evidence that word games, puzzles, or other, I would guess, cognitively stimulating activities help slow development of dementia or its symptoms?
Yeah, so we talk about physical exercise as being, perhaps the most important thing, physical activity, moving, getting the blood pumping being very important. And then, we do feel that mental stimulation is important. Now, whether there's anything special about these brain games, whether it be, Lumosity or Posit Science, or just, playing chess or word games or crosswords, I think the jury's still out. Mental stimulation is important, and whatever form. And I think that it is good to be challenging your brain, but not overstressing your brain. And I think the other thing related to that, when I talk about mental stimulation or games or things like that, I want to put a pitch in for social engagement and social interaction, because there's nothing that really enlivens the brain or uses more of your brain than interacting with another person. Have a conversation, reading a person's emotions on their face, remembering the conversation that you're having. There's nothing more stimulating than, and more engaging to the brain than engagement with another person in real time.
Okay. All right. I don't see any other questions, although one I had was, something that you brought up just a few minutes ago was, environmental factors in terms of, development of memory loss or dementia. Is there any evidence or any research being done, to address that concern in terms of what in our environment might be impacting that?
Yeah, so there's a lot of epidemiological, big scale epidemiology research going on, but drilling down into which specific pollutants or something there is, it's been very, very difficult. I mean, there are some things like with Parkinson's disease, there seems to be an association with certain insecticides that are used in farming and agriculture. So you can pull those things out. With Alzheimer's disease, again, because it is such a heterogeneous disorder, it's been harder to nail down. But clearly, if you're exposed to more traffic, if your house is closer to an interstate roadway, it appears that the risk is a tiny bit higher, but significantly higher than if you're living in a non-polluted atmosphere. There are other specific things that are related to neurodegeneration. So, I sometimes joke with my patients, asking them about their habits and, whether they're a weekend welder or anything, do they weld in their garage? And, I got one person who said yes, but manganese exposure in welding is something that can cause neurodegeneration and can cause dementia. So we always ask about things, but in the bigger picture for things like Alzheimer's disease, it seems like there's some risk associated with it, but we don't know what, we don't know how much, and we don't know where.
Gotcha. One other question I get a lot, sometimes from families that I work with is, are there any tests or is there any research being done trying to figure out ways to either detect, the disease, before symptoms develop? Like if somebody were 45, 50 years old, is there anything that they can do to see whether or not they're higher risk of developing memory loss or dementia later in life?
Yeah, so that again, there's a lot of layers to that question. Last week we had here in Boston, and this was the first in-person meeting that I've gone to in a year and a half or 2 years, was the CTAD meeting, the Clinical Trials in Alzheimer's Disease. So people from all over the world were coming in to kind of present research on clinical trials, and the thing that is, I think we're on the cusp of, which I really feel is going to be a transformational thing, is the availability or the improvement in blood-based biomarkers. So a blood test, particularly for phosphorylated tau, phospho-tau, which is one of the key markers that we've only been able to measure in spinal fluid. It looks like now, and this is including work that we've been doing here at Mass General for a while, it looks like the tests are sensitive enough that they can actually detect this protein with a blood test. So we may be, and we don't know yet because the research is still ongoing, but we may be able to use a blood test to detect whether there's an abnormal level of phospho-tau, suggesting that someone is developing some Alzheimer's disease in their brain. Now, just because we can do that doesn't mean we understand or we should do that. Because what if you're developing it and we don't have any way to stop it, really, other than some of the things that I talked to you about before, the physical exercise and lifestyle change and education and mental stimulation. We didn't talk about another risk factor for dementia and Alzheimer's disease, which is stress. And I can go into that, but would a blood test cause more stress and actually increase the risk on the basis of stressing someone out because they're worried all the time that they're developing Alzheimer's disease and they're just waiting, every time they can't remember someone's name, they have a panic attack because they think they're developing Alzheimer's disease, which is by no means, the case. So, I think that from a research perspective, we're going to need that tool of the blood tests for Alzheimer's disease in order to be able to prevent the disease. But what is the benefit of finding that out in clinical practice or for general use? I don't think that that's established yet. And so that gets into, there are a lot of questions about ethics and things that we should, we could talk about.
Right. All right. So I think the last question we have time for, is there a skin biopsy now available to determine the type of dementia, specifically Lewy body dementia versus Alzheimer's?
Not yet. So skin biopsies have a lot there's a lot that we can do with them in research because you can actually take the cells in the skin and in the lab, you can actually change those skin cells into neurons, into things that look and act like brain cells. So there's been a lot of work to see whether you can see some of these abnormal protein molecules that I mentioned in skin cells to say whether someone has Alzheimer's disease or Parkinson's disease, looking at a skin cell, maybe even transforming the skin cell in a lab dish and measuring different proteins. There's been work to try to see if you can do that and how well that correlates with what is happening in the brain. But it's by no means ready for prime time. I think it's a very, very useful research tool, but and will be, and actually getting back to, one of the things, the ideas that we've been kicking around here is related to that cancer question earlier that I liked so much, was that, if you can take some skin cells from someone and change them into things that look like brain cells, and then see whether one medicine will act on the skin cell and use those skin cells to screen for a medicine that might be right for a given person, that would be a really exciting thing. But this is just an idea right now, so don't. And it's part of the, it's part of the why I love. I came to Mass General about 5 years ago from Philadelphia to kind of start this clinical trials program. And it's one of the joys of being here is that there's so many smart people thinking about these creative ideas that you can, and actually you can do something about it. You can work with them to kind of, really move the field forward. So that's part of the joy of my being here, is getting to interact and think about these kinds of creative ideas.
Absolutely. All right. Well, looking at the time, I believe that is all the time we have. Dr. Arnold, I think I speak on behalf of everyone, including myself and the rest of the Dementia Care Collaborative, in saying that this was a fascinating, talk. I think everybody was able to ask some really great questions, and we were, I think it was fantastic and very interesting. So thank you so much for your time.
Great. Well, thank you.
One thing I just wanted to say to everyone, just a couple things. Number one, just to expect to receive an email regarding evaluation for tonight's talk. Feedback is always greatly appreciated. So if you can fill that review out for us and send it back, we would be very, very grateful. And one other thing is that the next conversation with caregivers to be on the lookout will be for December 14th. So it'll be a little different this month. We're doing it on the second Tuesday of next month instead of the third, like as per usual, just to kind of account for the holiday seasons. We welcome the photographer Joe Wallace, who will be sharing his traveling exhibit and portraits of dementia. The goal of the exhibit is to destigmatize those living with dementia and to use empathy as a means of connection and understanding. His work tells a more complex and complete story of those living with the disease and its effect on families and loved ones. So I hope you all can join us for that talk. I think it'll be really great. So, but as always, we want to thank everyone for joining us this evening. And I hope that all of you were able to take away something from this conversation today. And with that, I hope everyone has a wonderful evening.